Namaste. I am Dr. Sudhir Shandilya, working as Professor of Orthopaedics at Pacific Medical College, Udaipur, Rajasthan. Diagnosis in orthopedics, as in all the branches of medicine, is the identification of the disease. It begins from the very first encounter with the patient and is gradually modified and fine tuned until we have a picture not only of a pathological process but also of the functional loss and the disability that goes with it. After my personal experience in orthopedics, for more than 40 years now, I have devised an 8-step formula for approaching any orthopedic disorder. Today, we will discuss that formula. But before proceeding further, let me tell you about my 9 life principles, which I want all of you to imbibe in your life also to become the best orthopedic surgeon and the best human being as well. The first principle is Satya. We will always practice the science of orthopedics truthfully. We will never cheat anyone. Second, Prem. We will practice orthopedics with love and care for our patients. Third, Seva. We will serve them the best. Fourth is Yukti. Means we will learn all the newer techniques to solve various practical problems in day-to-day practice. 5. Bhakti. Bhakti means we will learn orthopedics consistently and persistently daily. And 6. Shakti. Shakti means we will use all the latest possible instruments and equipments and knowledge to provide the best service to our patients. 7. Tan. Tan means while serving our patients with full dedication, we will never neglect our own health. We will take all possible care to prevent spreading the infections. With regular exercise routine, we will maintain our own physique and health. We will not indulge in bad eating or drinking habits. 8th, Man. Man means we will always keep our minds strong without getting fatigued due to the workload. We will maintain the work-life balance. And 9, Dhan. Dhan means we are doing or practicing art of orthopedics to make money in most ethical ways without misguiding any patient. We will not become rats in the rat race of making big money. Before we discuss this formula, we must realize that understanding about the orthopedic disorder evolves from the systematic gathering of information from the history, the physical examination, tissue and organ imaging, and special investigations. While doing so, one must be systematic, but never mechanical. Behind the inquiring mind, there should also be what D.H. Lawrence has called the intelligent heart. It must never be forgotten that each patient has a unique personality, a job and hobbies, a family and a home, all have a bearing upon and are in turn affected by the disorder and its treatment. The 8 steps of my formula to approach any orthopedic disorders are as follows. Step 1, history. Step 2, writing all the chief complaints in a chronological order. Step 3, constructing the logical history of presenting complaints and guess the possible tentative diagnosis having anatomical and etiological components. Step 4, proceed for the clinical examination, keeping the guess of a tentative diagnosis in the mind. Clinical examination has 3 parts. 1, gait examination. 2. Head to toe, good general physical examination. And 3. Local examination, again in 5 steps. Look, feel, move, measure, and special clinical tests. Then comes the step 5. Arrive at a provisional diagnosis having 4 components. Also think of other differential diagnoses. Step 6. Decide the investigations to be done to confirm your provisional diagnosis. Step 7. Final diagnosis with 4 components. And final, step 8. Formulate the treatment plan. Now let us discuss each step in detail one by one. Step 1. History. Taking a history is a misnomer. The patient tells a story. It is we, the listeners, who construct a history. The story may be maddeningly disorganized, but the history has to be systematic, carefully and patiently compiled. It can be every bit as informative as examination or the laboratory test. As we record it, certain keywords and phrases will inevitably stand out. What are those words? Injury, pain, stiffness, swelling, deformity, instability, weakness, altered sensibility, loss of function, inability to do certain things that we were easily accomplished before. Now, remember, patient may not tell you all the truth. There may be a story told versus story untold. For example, a lady with a case of nightstick fracture may not tell you the truth. Instead, she may tell that the injury is due to fall in bathroom. Sometimes the story may be falsely exaggerated or inflated. You need not agree with everything. You need to take it with a pinch of salt. See, at the end, you must remember the aim of listening to the story of the patient empathetically to guess the possible diagnosis having two components, anatomical diagnosis and the etiological diagnosis. While compiling the history of patient's illness, each symptom is pursued for more details. We need to know when it began, whether suddenly or gradually, spontaneously or after some specific event, how it has changed or progressed, what makes it worse, what makes it better. While listening, we consider whether the story fits some pattern that we recognize, for we are already thinking of a diagnosis. Every piece of information should be thought of as a part of a larger picture which gradually unfolds in our understanding. The surgeon philosopher Wilfred Trotter put it well: disease reveals itself in causal parentheses. We must remember two important facts about commonly seen orthopedic disorders. One, most of the musculoskeletal disorders result in dysfunction of one or the other joint. And hence, you need to know commonly occurring disorders around various joints. Second, 8 categories of the orthopedic disorders commonly encountered. These are 1. Traumatic, 2. Infective, 3. Metabolic, 4. Neoplastic, 5. Congenital, 6. Inflammatory, 7. Developmental, 8. Miscellaneous. Important points to be remembered during reconstructing the history of illness are as follows. First point, it is the most important step. You must listen to the patient's story empathetically. It may be haphazard and disorderly. You need to rearrange the facts to create a chronological history. Second, you must focus and include demographic information of the patient. This includes full name of the patient, its age, sex, residential address, occupation, and date of admission. Why? Because this will prevent treating a wrong patient. There may be two patients with the same name but the two different illnesses, or treating or operating on a wrong limb. Now, in step 2, writing the chief presenting complaints in a chronological order. This will help you in two things. One, you will come to know the natural progression of the disease. And two, you will be able to guess a probable diagnosis. Because by this time you know which part of the body is most likely affected. We call it as an anatomical diagnosis. And two, what is the likely pathology. With this knowledge, you will be asking few leading questions about the illness, its past history, family history, and personal history. This will either support or negate your guess of the diagnosis. And at the end, you can have a tentative diagnosis in mind. Keeping this tentative diagnosis in mind, you will proceed for clinical examination of the patient. Now you know what is to be looked for during the clinical examination as per your tentative diagnosis in mind. You will not miss any important clinical finding if you keep certain tentative diagnosis in your mind. During this process, you have to consider various elements like age, sex, trauma, fever, etc. Let us discuss these elements briefly. We ask for the age of a patient. Why? Because certain elements are more common at a particular age group. As you can see in this particular table, if patient is less than 1 year old, possibility of CDH and CP is more. Usually, the patients between 1 and 2 years are brought to an orthopedic surgeon for nutritional rickets or poliomyelitis or an Ewing's tumor. Diseases like TB hip and Perthes, they are prevalent in the age group of 5 and 10 years. 15 to 20 years is the age of rapid growth when the incidences of slipped capital femoral epiphysis are more. All acute myelitis cases are prevalent before the age of 15 years. For bone malignancies, the common age group is 10 to 20 years. Rheumatoid arthritis is commonly seen 30 to 40 years. All degenerative disorders, PIVDs, and multiple myelomas are seen after the age of 40 years usually. Similarly, certain orthopedic disorders are more prevalent in males and others in females. For example, Perthes, slipped capital femoral epiphysis, traumatic disorders, multiple myeloma, and congenital talipes equinovarus is prevalent in males. Whereas rheumatoid arthritis, CDH, osteoporosis, Colles fracture, fractured neck of the femur are commonly seen in females. While listening to the story of the patient's illness, when it comes to the history of trauma, you must ask following points. One, ask about the onset. That is, if the trauma was acute and sudden, or it was a gradual repetitive trauma. Example of sudden trauma is road traffic accident. Whereas one gets repetitive trauma by using heavy duty drill machine as used to dig roads. Second, you must also think if the trauma is a causative factor for the present complaint or illness, or if the history of trauma is a predisposing factor for the present complaint or the disorder. Trauma as a causative factor is seen in cases of fracture, dislocations, sprains, strains, subluxation. Whereas trauma is a predisposing factor for TB hip, Perthes disease, slipped capital femoral epiphysis, osteogenic, osteogenic sarcoma, and acute osteomyelitis, etc. As far as the history of fever is concerned, we should ask if the fever is of high grade or low grade. Fever, it may be high as in acute osteomyelitis or low grade as in tuberculosis. We can also inquire about the fever pattern. Fever with different etiology will have different patterns. And based on the fever pattern, one can know what are the possible causes of the fever. When patient talks about the pain, you need to know if the pain is continuous or intermittent. Continuous pain indicates continuous pathology. Pain may be of low grade or high grade. Chronic infections like TB will give low grade pain, while acute fractures, dislocations, or acute disc prolapse with sciatica may be having high grade pain. For pain, there will be some aggravating factor and some relieving factor. For example, mechanical backache will aggravate with work and will get relieved with rest. However, the backache due to the port spine or multiple myeloma will not be relieved with the rest. One should also be on the guard about the radiating pain, as these often mislead the examiner. A pain due to cervical spine may radiate from shoulder to arm, forearm, and even up to fingertips. Similarly, pain due to shoulder pathology will radiate to the arm and elbow. Pain due to elbow pathology will radiate to forearm. Thoracic spine pathology usually causes girdle pain. Lumbar spine pathology will lead to radiating pain in groin, buttocks, posterior thigh, legs, and foot. Hip pathology will cause radiating pain to the knees. Often, children with TB hip complain of the knee pain first. You need to differentiate radiating pain from the referred pain also. The referred pain is defined as a pain felt at a site different from that of an injured or a diseased organ or body part. For example, angina. The pain of coronary artery insufficiency may be felt in the left shoulder or the scapular region. See this figure. It depicts the referred pain due to pathology at different organs. For example, small intestinal pain felt around the umbilicus. Now, any constitutional problems like weight loss, anorexia, etc., if present, are pointed towards neoplasm, tuberculosis, etc. Seasonal variation, if present, it is suggestive of rheumatoid disorders. Apart from these points, relevant past history, socioeconomic status, and personal history should be taken into account. Now, at the end of history taking, an attempt should be made to place the problem into one of the following categories. It will help you arrive at a guess of tentative diagnosis. The different categories in which you may try to fit the diseases are congenital, developmental, infective, inflammatory, metabolic, endocrinal, traumatic, degenerative, neoplastic, and idiopathic. Look at this chart and ask yourself, is the problem congenital? If so, it will be present since birth or seen within a few years from the birth. A strong family history is elicitable. Is it developmental? Here, the disease is manifested during the process of development. Is it infective? History of fever, chills, rigor, sweating, etc. are present. Is it inflammatory disorder? Seasonal variation, remissions, and exacerbation, multiple joint involvement, etc. are present. Is it metabolic? Nutrition, socioeconomic status, generalized skeletal disorders, etc. assume importance in this group. Is it an endocrinal disorder? Look for other evidences of hormonal imbalance. For example, hypothyroidism, you will find cretinism. Hypopituitarism, you will find dwarfism. Is it traumatic? History of fall, road traffic accident, assault, etc. is elicited. Is it degenerative? Advancing age, slow progress is the hallmark. Is it neoplastic? Look for the features of either benign or malignant bone tumors. If it cannot be categorized into any of the above, then it could be idiopathic. Having made a tentative diagnosis at the end of history, next important step is resorted to. And thus, at the end of a history of presenting illness, you must be able to guess a tentative diagnosis. This is our stage 3. Which part of the body is diseased? What is the likely disorder? And any other differential diagnosis. Keeping this tentative diagnosis in mind, we proceed for the step 4, that is the clinical examination. Now, this step number 3 of guessing a tentative diagnosis is the most important step. As without this tentative diagnosis, you cannot decide on what is to be seen in the patient to either support or refute your diagnosis. It is very much similar to the instance of a housewife entering into a kitchen to cook a delicious dish for her husband, but unless she has decided what has to be cooked, how can she look for various ingredients in the kitchen? Now, step number 4, after guessing the tentative diagnosis, which has minimum 2 components, that is the anatomical diagnosis and a possible guess of etiological diagnosis, we proceed for the clinical examination of the patient. The clinical examination usually starts with the examination of a gait of the patient. Later, we do the examination in 2 parts. First, the general physical examination, and second, the local clinical examination. Again, the local examination is done in 5 stages. 1. Look. 2. Feel. 3. Move. 4. Measure. And 5. Special clinical tests. We must remember the fact that a good systemic clinical examination will help clinch the diagnosis with certainty. No sophisticated technology can replace the value of a good clinical examination. A good clinician will make the diagnosis clinically and will make use of the investigation armamentarium judiciously. A clinician should command the investigation and not vice versa. The aim of clinical examination is 1. To clinch the provisional diagnosis with certainty. 2. To decide the various investigations to be done. And 3. Then with the final diagnosis in hand, decide the holistic plan of the treatment. The examination of a locomotor system involves 4 steps. Examination of a gait, step 1. Step 2, general physical examination. Step 3, local examination involving look, feel, move, measure, and special test. And 4th, the investigations. Let us start with an examination of the gait. It is extremely important as it gives vital clues regarding the diagnosis. What is the definition of gait? It is a term used to describe the style of walking. This is dependent not only on the normal muscles and joints, but upon an intact central nervous system, CNS, peripheral nervous system, PNS, and normal labyrinthine function as well. Now, walking is divided into two phases, the stance phase and the swing phase. The stance phase forms 60% of the gait, and here the foot is on the ground. Look into the picture. It is further subdivided into heel strike, that is the heel striking the ground, mid stance, where the foot is flat on the ground, and push off, where the foot is off the ground. The swing phase, this forms 40% of the gait cycle, and here the foot is not in contact with the ground. Look at the picture. It is further subdivided into three. Acceleration. Here the leg is in front of the body. Swing through. Here the leg continues to swing forward. And stage 3, deceleration. Swing slows down and heel is ready for the strike. In normal gait, each leg alternatively goes through a stance phase and a swing phase. Thus, the body is carried forward in normal walking by these rhythmic cycles. Running gait. Here, the sequences are the same as in walking, but are faster. Now, after knowing about the normal gait cycle, let us know about various abnormal gait and probable diagnosis. The first common abnormal gait is antalgic gait. In this, stance phase duration is decreased, and this type of gait is seen in any painful lesion of either foot, ankle, knee, or hip. In the gluteus medius gait, there is a lurch of body towards the affected side during every stance phase. This gait is seen when the gluteus medius muscle is paralyzed. Similarly, when the gluteus maximus muscle is paralyzed, for example in poliomyelitis, there will be a backward lurch while walking. We call it as a gluteus maximus gait. Look into this particular diagram. Now, the patients of cerebral palsy, due to the spastic adductors, they walk with legs crossing. It is called as a scissors gait. Whenever there is a shortening of one lower limb more than 2 inches, patient walks with dipping on the affected side. We call it as a short leg gait. Now, this shortening may be acquired or congenital. In septic hip arthritis, hip becomes stiff and patient walks with no flexion at hip. This typical gait is called the stiff hip gait. When the quadriceps are weak, the patient will walk with the hand on the knee, as shown in this particular picture. We call it as the quadriceps gait or the hand knee gait. If the pelvis drops down on the side of the unsupported limb while walking, we call this type of walking as Trendelenburg gait. Now, this usually happens in DDH or old traumatic hip dislocations or non-union of fracture neck of the femur case. In the patients with the calf muscle weakness due to any reason, whenever patient walks, there is no push-off seen. We call it as a calcaneal gait. In the patients of septic arthritis knee with the stiff knees, patient has to walk by raising the pelvis during the swing phase. This is known as the stiff knee gait. In case of spinal cerebellar ataxia, child walks with legs apart. This is known as ataxic gait. Hysteric patient walk with abnormal gait which keeps on changing. We may call it as hysteric gait. After the gait examination, the next step in the clinical examination is that of general physical examination. A good general physical examination or GPE from head to toe gives vital clues in the diagnosis of most of the orthopedic disorders, particularly generalized disorders of the skeleton. For example, metabolic disorders like rickets or developmental disorders like osteogenesis imperfecta. It will also help us detect various comorbid conditions like anemia, TB, hypertension, diabetes, etc. We can also detect any other coexisting orthopedic condition. Now comes the step 3, the clinical examination per se. Now during this examination, we need to consider symptoms. The following are the usual presenting symptoms in a patient with orthopedic disorder. The first symptom is pain. This is the first and the most common complaint. It is a highly subjective complaint and can be classified as mild, moderate, or severe pain. The must ask questions regarding the pain are: how did it start? Is it related to trauma? What is the site of the pain? Does it radiate? What are the aggravating and relieving factors? Does it interfere with the sleep, etc.? The second most important symptom in orthopedic cases is a swelling. Now, it may precede or follow the pain. Relevant questions to be asked are the site of swelling, painful or painless. Is it rapidly growing, for example, in malignancy, or slow growing, benign growth? Is it associated with fever, chills, etc., suggestive of infective origin? Is it single or multiple, for example, in neurofibroma? Also look for the size of the swelling. The third common symptom is deformity. Sudden onset of deformity is usually seen in fresh fractures and dislocations. Long-standing deformities are usually seen in old fractures and other non-traumatic disorders like congenital, developmental, and metabolic conditions. In TB knee, one may get a triple deformity at knee. Patient may complain of cosmetic or functional impairment due to the deformity. Then the next common symptom is limitation of joint movements. In the initial stages, this limitation may be due to the muscle spasm. And in later stages, it may be due to the intra-articular adhesions, for example, in TB or septic arthritis, rheumatoid arthritis, or extra-articular contractures like post-burn contractures, Volkmann's ischemic contractures, etc. The fifth one is the limp. Limp is defined as an uneven, jerky, or laborious gait, usually caused by pain, weakness, or deformity. Limp can be caused by both benign and life-threatening conditions. The management varies from reassurance to major surgery depending upon the cause. Now, the limb could be painful, for example, in arthritis of the hip or the trauma, etc., or it may be painless, for example, in CDH, Coxa-Vara, etc. The patient may complain of difficulty or alteration in various day-to-day activities like walking, squatting, running, working, etc. The next common symptom is limb weakness. Now, this may be due to disuse atrophy, motor problems like polio, motor neuron diseases, muscle problems like muscular dystrophies, or due to peripheral or diabetic neuropathies. Even the peripheral neuropathy due to the avitaminosis may cause the limb weakness. Now, after considering various symptoms as above, you should look That second step, inspection for the relevant signs. Every symptom will have a associated sign. In general, look for the signs of anemia, fever, weight loss, etc. Then, locally, look for the attitude of a diseased limb first. How does the patient carry the affected limb? For example, a case of anterior dislocation of shoulder, patient will carry the affected limb supported with the other limb and the affected shoulder kept in flexion, abduction, and external rotation. Now, attitude means the position in which the diseased limb is kept for maximum comfort. In synovitis stage of TB hip, patient usually carries the limb with hip flexed, abducted, and externally rotated. Now, look the part of the diseased part from all sides, focusing on the skin and then underlying muscle and then the bony structures in a proper sequence. Deformity may be due to abnormality of a bone or a joint. If a joint is out of anatomical position, a deformity is said to exist. In addition, in case of a bone, deviation from its normal anatomy is deformity. In cases of old fractures and dislocations, the deformity may be fixed. A fixed deformity is the angle between the neutral position of the normal joint and the position of a deformed joint will reach. Now, after what you look, that is what you have inspected, you need to confirm your inspection findings by palpation. We call it a step of feel. Start feel by feeling for one, temperature first, then tenderness. Check the temperature with the dorsum of your hand, compare with the normal side. Later, you need to feel for the tenderness. Now, what is tenderness? Tenderness is pain on palpation. This is elicited by examining from the normal to affected area, and this tenderness is graded 1 to 4. Remember these 4 grades. Grade 0, no tenderness. Grade 1, winces on pressure. Grade 2, winces and withdraws. And grade 3, doesn't allow to touch. Then palpate normal anatomical structures locally from skin, muscle, underlying bone structures in a proper sequence. In case of swelling, the following things are to be noted in examination of a swelling. First, decide the anatomical plane. The plane of the swelling could be either bone. Now, when it is the bone, swelling decreases in size when the muscle is put into contraction. Or it could be in the muscle. The swelling slightly decreases in size and gets fixed on the muscle contraction. Or it could be between muscle and the skin. No change in the size at the swelling when the muscle is put into contraction. Also examine the level of the swelling and identify whether it is epiphyseal, metaphyseal, or diphyseal. Look at the diagram here. Then describe the shape of the swelling. It could be globular, it could be oval, round. Describe the size of the swelling and then grade the consistency. Again, 5 grades of the consistency have been described. The 5 grades of the consistency are grade 1, very soft, like jelly. Grade 2, soft, like a relaxed muscle. Grade 3, firm, like a contracted muscle. Grade 4, hard, like a contracted biceps. And grade 5, stony and bony hard. Now decide whether it is congenital or neoplastic. Look for slipping sign, emptying sign, indentation, expansile impulses, etc. With this, We finish the second step of clinical examination. The first step was to look and second step was to feel. Now we proceed for the third step, that is move. We will move the joints. Now movements of joint could be active movements and the passive movements. Active movements, the patient himself moves the joint in one direction and later in other. The extent of the active movement is noted. Now the joints on both sides should be tested. Passive movement of a joint is tested by the examiner without causing pain. The extent of the passive movement is also noted. Remember, limitation of all movements of a joint indicates arthritis, whereas limitation of certain movement of a joint indicates an extra-articular lesion or a mechanical block. If the passive movements exceed the active movements, then paralysis of the muscle is likely. Then comes the fourth step, that is measurements. Accurate limb length measurements give vital clues regarding the diagnosis. Measurements should be taken for two purposes. One, to know the limb length. For this, measurement is taken between two fixed bony points and is always compared with the normal side. In upper limbs, the arm length is taken from the angle of acromion to the lateral epicondyle of the humerus. The forearm length is measured from the lateral epicondyle of humerus to the radial styloid process. Whereas in the lower limb, the thigh length is measured from anterior superior iliac spine to the medial knee joint line, and the leg length is measured from the medial knee joint line to the medial malleolus. To know the apparent length of the lower limb, measurement is taken from the sternum to the medial malleolus. The second is we do the measurements to know the girth of the limb, to detect wasting of the muscles. The circumference of the limb is measured at a fixed point on both sides. For example, 18 centimeters above the joint line in a thigh. Finally, do various special clinical tests to diagnose specific regional conditions. For example, McMurray's test, or Slocum's Draver test, or Apley's grinding test, or Dugas test in anterior shoulder dislocation, or Barlow's ortolani's telescoping test for the hip dislocations in child, Tredelenburg test, Gallazzi test, Allen test, etc. Irregular thickening of a bone and a persistent discharging sinus, if this is present, along with the scars fixed to the bone, it indicates chronic osteomyelitis. And finally, the peripheral, vascular, and nervous system examination should be done next. Now, let us see the quick facts about sinus tracts. The causes of persistent discharging sinuses include 1. Unobliterated cavities, 2. Unabsorbed sequestra, 3. Epithelialization of the sinus tract, 4. Presence of foreign body, 5. Secondary infection, 6. Diabetes and steroid therapy, and 7. Malignant changes in the sinus. Now, in the fifth stage, you need to write down all your findings chronologically and systematically. Read your write-up once and reread. Think about the tentative diagnosis you had kept or you had guessed before you started the examination. And now think, what are the positive supporting findings? What are the negative points for the case diagnosis? Is there any other differential diagnosis? Write it down. At the end of this step, number 5, you must be able to decide the provisional diagnosis, and your provisional diagnosis must contain following 4 components. First, anatomical diagnosis. Which part of the body is diseased? Second, etiological diagnosis. What is the disease? Third, morphological diagnosis. What morphological changes that disease has caused in the body? And fourth, comorbid condition. What are the other important comorbid conditions present which will necessarily modify or affect your plan of treatment? Now, once you have arrived at the provisional diagnosis in step 5, you will go to the step number 6 of deciding various investigations to be done to confirm or refute your provisional diagnosis. Now, these investigations include radiological investigations like X-rays, MRI, CT scan, etc. Routine and special blood, urine, and other body fluid investigations. All these helps to confirm the diagnosis. Sometimes only X-ray makes the diagnosis. For example, crack fractures of the bone, they are diagnosed by X-rays only. Now let us discuss few important aspects about the radiological investigation. The very first thing is to learn the proper way of prescribing the investigation. The prescription form must be filled by doctor himself, giving all important details of the patient. Look at the adjacent X-ray form, which is filled. You must write name, age, sex, date of admission, complete diagnosis with the side left or right, and the investigation required. If you require, you may also mention your intention for the said investigation in the footnote. Similarly, you must learn to prescribe CT and MRI and other radiology and pathological prescriptions properly. Now, while taking the X-ray, handle the injured limb gently and carefully. For this, you may give traction to avoid pain. If you can take X-rays without moving the injured limb, you need to see that. For example, moving uninjured limb or the X-ray tube itself. At least two views, AP and lateral, should be taken. Two joints, proximal and distal, should be included. Additional oblique spatial views can be taken. May also include normal side for comparison. You may also take X-rays with the fractured limb interaction to see the reducibility of the fracture or to know the exact fracture pattern. For example, X-ray hip with the traction and 10 to 15 degrees of internal rotation is taken for viewing the proximal femur in a profile view. Now, these are some certain ways of taking X-rays without hurting the patient. In the first picture, in a cross-table view, the normal hip is flexed to avoid overlapping. X-ray cassette is placed laterally. X-ray tube is positioned medially, and the lateral view of the injured hip is taken. It is better if the resident doctor visits the radiology department along with the patient to take such views. The second picture is showing a method of taking lateral view of a reduced supracondylar fracture humerus in a plaster without twisting the limb, keeping the shoulder in extension. The third picture is depicting the ways of taking spatial views, that is Harris axial view of the calcaneum in suspected cases of the fracture calcaneum. Now, CT scan is prescribed to study the bony anatomy precisely. For example, in case of a tibial plateau fracture, we need to know precisely the anatomy of the fracture fragments so that they can be fixed accurately. Whereas MRI is prescribed to diagnose soft tissue lesions such as the rotator cuff tear or the ACL rupture, etc. Now, to study the vascularity of the bone, for example, in avian hip or a fracture neck of the talus, etc., one may require angiography or bone scans. PET scan helps us to know the bone metastasis. Bone biopsy helps in histopathological confirmation of malignancy and other bone pathologies. Now, after getting various investigation reports, your seventh step is to decide the final diagnosis. This final diagnosis will, of course, have four components as described earlier. The first component of anatomical diagnosis will tell which part of the body is diseased. The second component of etiological diagnosis will talk about the disease itself. The third morphological diagnosis describes the morphological changes the disease has caused in the body and the disease part. Associated comorbidities form the fourth component. You must make a habit of telling the complete diagnosis, having four components every time. This helps you to formulate the plan of treatment holistically. Let me give you an example of a complete diagnosis. For example, instead of simply saying it is a case of TB hip right side, will it not be better if you say that it's a case of tuberculous arthritis stage 3, etiological diagnosis, of right hip, anatomical diagnosis, with 20 degrees of fixed flexion, 30 degrees of fixed adduction, 20 degrees of internal rotation deformity, with 1.5 centimeter of true supratrochanteric shortening of right lower limb, a morphological diagnosis, with hypoproteinemia and anemia with chronic alcoholism and uncontrolled diabetes, comorbidity. Now, don't you think by stating the complete diagnosis, having the four components, will it not help you formulate a better treatment plan? Now, you can formulate the plan as follows. First, treatment of the chief complaint, pain and disability. Second, treat the disease, anti-TB chemotherapy. Third, treat the comorbidity, treat anemia, hypoproteinemia, diabetes, counsel for the alcoholism, etc. And fourth, correct the deformity or shortening. Maybe you may plan for the THR. Thus, the last step, number 8, formulating the treatment plan. Once you have arrived at the final diagnosis having four components as described earlier, now you can formulate the treatment plan as under. First, relieve the chief complaint of the patient. Most of the time, the chief complaint is the pain. Second, then treat the underlying disease. Say, if the pain is due to infection, treat the infection. 3. Then think of the morphological changes which may require the treatment. And 4. Always consider the comorbid illnesses and treat them as well, which will facilitate the main treatment. Pre-operative and post-operative counseling of the patient and his or her relatives is equally important. Post-operative physiotherapy and occupational therapy must not be forgotten. Proper post-operative instructions at the time of discharge must not only be written on the discharge card in a local language, but they must be explained verbally to both patient and his or her caretaker. This instruction must also include care of the operated limb, diet, day-to-day activity modification, and the next follow-up date. This completes my 8-step formula for approaching any orthopedic case. Before I end this discussion, I want to emphasize following things to you. Please watch this video at least 20 times. Sit with your professors or seniors in OPD and observe how do they approach the patient. Attend ward rounds with them regularly. Discuss with seniors. Read the textbooks regularly. Don't hesitate to ask your queries. Remember, the mantra for success is ask, ask, and ask. Practice, practice, and practice. Thank you so much for patiently watching till the end. If you have liked it, please do share with others. Also, subscribe to my channel so that you can get the information about all the videos published in future. See you in my next video. Till then, stay happy and healthy. Keep learning. Be the best orthopedic surgeon and the best human being as well. Thank you.